Now I invite Dr. Pushkar to deliver his talk on orthostatic hypotension.
So, good afternoon everyone. Today I am going to present on orthostatic hypotension, which is a very important topic for any clinician, and it is very likely to be missed if we don't think of it. So, when should we suspect orthostatic hypotension? Any patient who presents with lightheadedness, fainting sensation, difficulty in standing up from lying down position, or difficulty in standing for long durations, patients coming with unexplained falls, orthostatic hypotension is more common than thought of. So, it is mostly missed as we do not suspect or check for orthostatic hypotension. So, what exactly is orthostatic hypotension? Orthostatic hypotension or postural hypotension is defined as a drop in blood pressure upon standing from a sitting or supine position or during head-up tilt test. The clinical diagnosis is made by sustained reduction in systolic blood pressure of at least 20 millimeters of mercury or diastolic blood pressure of more than 10 millimeters mercury drop within 3 minutes of standing after being supine for at least 5 minutes or on a 60-degree angle on the tilt table. The sudden drop in blood pressure usually happens, it is because of secondary failure of autonomic reflex, volume depletion, or adverse reaction to any medications. The symptoms, common symptoms which are present include lightheadedness or feeling fainting sensation, dizziness, spinning sensation or feeling off balance. Usually this spinning sensation is internal rotation. Patient won't feel that surroundings are rotating. There is a transient loss of consciousness or falls. Less common or non-specific symptoms include blurry vision, visual field deficits, difficulty in concentrating, cognitive slowing, weakness, fatigue, shortness of breath, chest pain, backache, lower extremity pain. There is something called a coat hanger pain or coat hanger headache, where there is a pain in the suboccipital headache and neck pain in the posterior cervical and shoulder areas. Many of us must have experienced that such kind of patients come, they tell ki we have pain in the occipital region, neck pain is there, and most of these patients land up with the orthopedic surgeon. But it could be a orthostatic hypotension. So how to diagnose orthostatic hypotension? We just require a BP machine. So in clinic, blood pressure and heart rate are measured at least 3 to 5 minutes of resting in supine position, ideally followed by measurements at 1 and 3 minutes of standing. Usually in a busy OPD, it is not feasible for everyone to allot so much time to a patient. So there is a criteria of 15/7 instead of 20/10, wherein we can make the patient stand up from sitting position. And if there is a drop of more than 15 millimeters of mercury on systolic and more than 7 millimeter drop in diastolic, either of these, orthostatic hypotension is acceptable, is considered with acceptable sensitivity and specificity. What usually I do, I advise patients to measure their blood pressure and heart rate at home. It is a very efficient screening tool and very affordable. All the patients can themselves measure their blood pressure at home. Patients can measure blood pressure and heart rate after lying down and resting. They can obtain BP and heart rate immediately, 3 minutes and 10 minutes of standing. And at least 2 weeks of log has to be maintained. And also we can advise the patients that when they are having maximum symptoms, if possible, they should measure their blood pressure that time, if there is a drop from the baseline. The other ways to diagnose are head-up tilt test and ambulatory BP monitoring. So what is ambulatory BP monitoring? So as we all are aware, ki BP is a very dynamic and condition, and one-time high blood pressure in a doctor's clinic, usually the patient land up with antihypertensives, which are not required by them. So just a single high blood pressure measurement in any physician's clinic or a general physician's clinic should not be a criterion to start antihypertensives. So ambulatory BP monitoring is a measurement of BP over 24 hours period, during daytime, during night time or hourly. It allows assessment of BP variability. Patients are more comfortable at home. Many times when the patients are present in the clinic, they have white coat hypertension, as we are all aware. So there may be a slight increase in the blood pressure. So that should not be the criteria to start antihypertensives immediately. And the other advantage of ambulatory BP monitoring is that when the patient is having maximum symptoms and the BP monitor is attached, so we can exactly come to know during the time of symptoms whether there was a fall in blood pressure or not. Because it may not be feasible every time the patient is having symptoms, you will be able to measure the BP immediately. And BP being a dynamic condition, After few seconds or 1 or 2 minutes, by the time the patient measures the blood pressure, BP may have come back to the normal rate. So what happens, what are the changes in BP on postural change? So there is a classic orthostatic hypotension which I already described. There is an initial orthostatic hypotension where there is a sustained drop in blood pressure for standing for 3 minutes or long. It may progress to classic orthostatic hypotension, and it is a milder form of sympathetic adrenergic failure. Delayed orthostatic hypotension, it is a transient reduction of systolic blood pressure by at least 40 millimeters of mercury or diastolic blood pressure of at least 20 millimeters of mercury. And transient drop occurs in 15 seconds of standing, and the BP recovers in 30 seconds. Though it is a benign phenomena, especially in young and adolescent patients, patients experience transient symptoms when there is a delayed orthostatic hypotension. There is a delayed BP recovery wherein there is an immediate and transient drop in blood pressure, but recovery is gradual within 30 seconds to 3 minutes. So common drugs which cause orthostatic hypotension, we should always take a detailed history of what medications the patient is taking to know that there could be these drugs which may be responsible for patient symptoms. So most commonly you will find that antihypertensive agents are responsible for orthostatic hypotension, and the other commonest thing is alpha blockers, which is used for prostate, benign prostatic hypertrophy. It is a very commonly prescribed drug, and that is notorious for causing orthostatic hypotension. These are various differential diagnoses which have to be kept in mind. There is a correlation between BPPV and orthostatic hypotension. The most important difference is that whenever a patient will come of BPPV, he will tell that he is worse on lying down. That is usually the case. Patient will tell, whenever I try to lie down, I am feeling worse. But a patient of orthostatic hypotension usually tells that he feels better when he is lying down. BPPV will present with nystagmus on positional test, which Dr. Srinivas has already described very beautifully. And some studies have shown that orthostatic hypotension can partially influence recurrences in BPPV. So like Dr. Dushyant was explaining the porous crystals, it could be that one of the mechanisms, since there is a decreased perfusion, it may be influencing recurrences. So we are not yet sure, but there are some studies which show that patients who are having recurrent BPPV, one of the reasons could be orthostatic hypotension. So whenever you have a BPPV patient who is having recurrent symptoms and he is not getting better, always think that there could be a chance of orthostatic hypotension and rule that out. These are the various causes of orthostatic hypotension: neurogenic, non-neurogenic. So any patient with dementia, Parkinson's disease, peripheral neuropathy, diabetic peripheral neuropathy may also have additional orthostatic hypotension. Treatment is non-pharmacological and pharmacological. Non-pharmacological therapy is very easy to administer, and we all can advise the patients. The first thing we have to tell them is do physical countermaneuvers like squatting, leg crossing, thigh contraction, bending at the waist. Salt supplementation has to be advised, a high salt intake along with increased water consumption. The most common mistake what everyone does whenever the patient comes with dizziness, they first advise is salt restricted diet, thinking that it could be a Meniere's disease. It may not be Meniere's disease, and if you restrict the salt further in such patients, their conditions is going to get worse. Water intake has to be increased. To expand the circulating fluid, water intake should be increased up to 2 to 2.5 liters per day. So there is a method which they have described, gulping a big glass of water, about half a liter of water within 10 minutes, raises the plasma norepinephrine level and increases the blood pressure quickly with peak effects in 20 to 30 minutes. So this can be advised to the patients in whom we cannot stop the offending agents, offending medicines. So before taking the medicine, say 15-20 minutes before they are taking the offending medicine, you can tell them to drink half a liter of water within 10 minutes. So that by the time the medicine starts to act, his BP is already raised and he won't have the symptoms. Compressive garments are very commonly advised, but they are very inconvenient to the patient, and patient compliance is very less. So in more than stockings, it is abdominal binder which helps, because the splanchnic circulation is increased in orthostatic hypotension, and abdominal binder helps to send back the splanchnic blood flow back, so it increases the venous return. And lifestyle modifications like prolonged standing, alcohol consumption, hot showers and saunas should be avoided as they augment vasodilatation. High carbohydrate foods can lead to postprandial hypotension. Diabetic patients usually, you will find that they complain कि after they are having food, खाना खाने के बाद उठ गए and they start feeling dizzy. So it cannot be hypoglycemia because patient has just had food. So one of the reasons is orthostatic hypotension. And because of high carbohydrate foods, again splanchnic circulation increases to digest that food and it can cause postural drop. These are various medicines which can be used. I don't have time to describe all the medicines, but these medicines usually have to be started in consultation with the cardiologist or neurologist. I usually do not start it myself. Preventive measures, you should avoid unnecessary medications and use of minimal medicines in elderly patients. Avoid salt restriction indiscriminately in all patients of dizziness. And especially young girls, you should advise dehydration should be avoided. I have seen a trend among the adolescent and young girls that they avoid drinking water throughout the day to avoid using public washrooms. This is a very disturbing trend and that causes orthostatic hypotension, or it may cause something called as postural orthostatic tachycardia syndrome, wherein there is an increase in heart rate of more than 30 beats per minute when the patient is changing position. From sitting to standing position, the patient increases, the heart rate increases without drop in blood pressure. So that's why I mentioned that while checking for orthostatic hypotension, we should always check for heart rate also. So this condition can be avoided. I have seen at least 7 to 8 patients between 15 to 25 years of age, young girls, after telling them to increase water intake, their symptoms disappeared without giving any medicines. So this has to be explained to the patient that these can cause long-term implications, and it is a very simple thing to do. To conclude, always suspect orthostatic hypotension in patients who are having symptoms on change of position. Take medication history very properly. Try all normal pharmacological measures in patients whenever, whatever is feasible, and take help of cardiology and neurology colleagues whenever required. These are various references. I would request the organizers to give you a detailed presentation which I have, a PDF, so that wherein all the details which I have mentioned will be shared with you. And this was just an overview so that you all get sensitized to this topic, and feel free to ask any questions at the end of session. Thank you.
Thank you very much, Dr. Pushkar, for a nice informative talk.